Good morning. It's always nice to be the first speaker. The last time I spoke here was right after lunch, so I'm really happy to be first this morning. So we're going to start today off with the really exciting topic of dental materials. I know you all love those classes when you were in school, but this is a new material that is old, and we'll go through the history of this material. So to start off with, I would like to say I have no financial disclosures. I don't work with the company in the US that provides this material, and I go to great lengths to do that because a lot of speakers on this new material do get paid by this company, and so I don't even order it in our division, so I can keep all of my financial disclosures very separate. So we'll start off. So this product has been available in other countries for a very long time. I've actually used this product since 2013 when we used to smuggle it in from Japan in these little tiny capsules. So you can see the Japanese writing on this. Silver diamine fluoride, SDF, has been used in many other countries in the world since the 1970s. But it's recently been FDA approved in the US, so we'll kind of go over the history of that. But I've used this material for a long time, probably one of the longest practitioners in the US because we did use it in an off-label manner, smuggling it in from Japan for so long. But that's kind of my background on how long I've been using this. Today we're kind of going to shift a little bit of paradigm for you. We're going to talk about the medical management of caries. We're also going to go over this history of silver ion use and what it does and how it's effective. And then go over the evidence that we have and how to actually use this material. And then go over when and how to use this material and when you shouldn't use this material. So has anyone heard of the medical model of caries management? It's fairly new, and you might recognize this in the Canberra and the caries risk assessments that you might go over with your patients. So the medical model of disease is based on risk, right? So if you're overweight, if you eat a lot of junk food, and you do this, you might be at risk for diabetes, right? And so your physician or your healthcare provider will talk to you about those risks. And so it's not a guarantee that you'll get diabetes, but you're at risk for those things. So we think about that in terms of dental caries as well, right? If you're eating lots of sugary foods, if you're not having adequate oral hygiene, things like that, you're at risk for getting a cavity. But we all know there's some people who never floss and never get a cavity, and those people are very lucky. But a lot of people, you're at risk for that. And so that's the medical management model. In this model, you make recommendations to your patients. So if you're overweight and not eating really well and your doctor says you're at risk for diabetes, you say, okay, we're going to lower your risk for diabetes. You're going to need to exercise. You're going to need to eat better. We might put you on some pre-diabetic medication, things like that. So this is what the medical model is. In dentistry, we kind of skipped the risk side of things for a really long time and went straight to the surgical model. So most of dentistry, and most of the history of dentistry, has just been drilling and filling, so taking out the disease, patching up those holes. We've skipped the whole medical management of things. And this is kind of analogous to if you have diabetes, not doing any prevention of diabetes, not doing any medical management of diabetes, but going straight to amputating the foot because of the sequelae or the consequences of diabetes. And that's where we've been stuck for a really, really long time in dentistry. We're trying to shift this whole paradigm into saying, okay, let's fix these holes before they happen. Let's look at the preventive things. Let's look at all the risk factors, and let's address those risk factors for each individual patient. So this is kind of where we are in this shift. And you might also see this in this paradigm shift, and you'll hear this more and more as this comes out. This is fairly new in the last 10 years of dentistry. It takes us a really long time to get our information out there. But it's, when you look at a patient, you look at their risk factors, right? So lots of bacterial counts, poor OH, xerostomia. You see those patients who've undergone radiation therapy or other cancer treatments and no longer produce saliva, and they all of a sudden just get tons and tons of carious lesions. If you have a diet rich in carbohydrates, like all the donuts out there, like I was having this morning, or if you have patients whose anatomy of their teeth have deep pits and fissures and just hold that bacteria in, those are those really big risk factors for developing dental caries. Balanced out with protective factors. So, if they have adequate salivary flow, or you live in a community that's fluoridated. Fortunately, in Minnesota, it's state statute that communities have fluoridated water. That's not the same in every state, and a lot of other states base their water fluoridation on their municipality. We also look at having a healthy diet and if the patient had access to sealants. I think dental hygiene is so important because your entire profession is based on prevention of dental caries. So you're really trying to shift that balance into the more protective factors so that patients don't get dental caries. So as a dentist, like, we kind of just started looking at holes first and patching holes and going straight to the surgical. We're trying to make that shift as a profession to look at more prevention, to look at more of preventing those holes from happening in the first place, to upping those protective factors so that those protective factors outweigh the risk factors that a patient might have. So this is sounding more familiar. It's something you've probably heard of, but we're kind of trying to quantify it in this medical management model. So in dentistry, for the longest time, we just had primary care, which you're familiar with, of like fluoride, oral hygiene instructions, diet counseling, like that kind of primary care of like preventing things from happening. Or we had the tertiary care, which is the surgical model, so drilling and filling of those holes. So these are restorations, these are extractions. We didn't really have anything to bridge that gap. In medicine, you think about it, there's a lot of bridging of gaps. There's not just prevention and not just surgical treatment. There's medicine in the middle. For the longest time, all we really had as a medicine was that really like high concentrations of fluoride, like your Previdents or other dentifrices with 5,000 parts per million fluoride. But now we also have SDF. And SDF, silver diamine fluoride, sits in this middle category of medicine. So it's a secondary care that is the use of pharmaceuticals to keep these lesions from progressing. So the lesions are there, but now we're going to keep them from getting bigger. So we're trying to introduce that into dentistry. So these pharmaceuticals, like I said, include your fluorides. And fluorides, as you know, are antimicrobial. They promote remineralization. They prevent demineralization. They're one of the best things we have to prevent dental caries. We also think of another pharmaceutical we have is chlorhexidine. It's both bactericidal and bacteriostatic, and it reduces that pellicle formation on the teeth. But it also, if the lesion's already there, it can prevent it from getting bigger, but it doesn't stop the lesion. And then we have silver compounds, which are antimicrobial in nature. And most of my talk today will be on silver compounds because they're relatively new in the US for using them. But we've actually used them for a really long time. I thought if I didn't go into all the science I did in my studies, I would have done history. And so we'll kind of go through the history part of it because I think it's really fascinating to see how things come back around. Who is familiar with G.V. Black? Yeah. Like father of modern dentistry. There's actually a statue of him in Lincoln Park in Chicago. So if you're ever there for a meeting, you can like just walk up the street and go and see his statue. And I was there looking at his statue one time and like taking a bunch of pictures, and someone was like, "Are you in dentistry?" And I was like, "Yeah," because there's no one else like taking pictures of this guy. It's like off to the side, kind of. You're like, "Oh, this is this weird person." But fun fact is, the G in G.V. Black stands for green. It was his mother's maiden name. So his real name is Green Vardaman Black, which I always find fascinating. So I hope you win at trivia one night for that. But this is G.V. Black. He's out in Colorado in this early photograph. He's studying the Colorado brown stain, which he didn't actually discover that fluoride was the cause of that, but he was part of the group that was in it. He unfortunately died before they finally figured out that fluoride was the mechanism that was causing that brown mottling and staining, but also preventing dental caries in that population in Colorado. So he's kind of one of the first people, and he's one of the first people who uses silver compounds in dentistry. And so, before the 1900s, so when G.V. Black was like riding around the US trying to change dentistry into a more solidified profession, he used silver nitrate for caries management. So silver nitrate is a common medical medicament, and he would just rub it on the teeth to get them to turn black. What he was trying to do is he would see these carious lesions come in, and he would note that some caries got really big and they led to abscess and infection, and that tooth would need to come out. But he would also see caries that came in and holes that were black, and it turned black. And we can see that in arrested decay sometimes when you see someone who hasn't been to the dentist in a long time. So he was trying to figure out a medicine that would turn them instantaneously black. He didn't really understand what the mechanism was, but he knew if he could get them dark, that they would be hard and that lesion wouldn't progress anymore. So that's kind of where he was going with this. But we've used silver compounds in medicine for millennia. The Romans used to put silver coins in their water jugs because that would prevent microbial growth. They didn't really understand the mechanism. They didn't have germ theory, but they knew if they put silver in those water jugs, it would prevent things from growing in there that would make them sick. We know that silver sutures in surgery have prevented lots of infections. Now, this is even before germ theory, so people didn't know why it worked. They just knew silver prevented lesions and cuts and bruises and other things from getting infected. So we've used it for a really long time. In 1917, you had a bunch of people kind of going around. These are your charlatans who are trying to sell your snake oil. And this is one of the snake oils that came out of that era that actually worked. So it's Howe's solution. It's a silver-containing solution that was used and painted onto teeth. And it was used for a really, really long time, up into the 1950s. So that was Howe's solution. It was marketed as a dental medicine. Then in the 1970s and 1990s, you start to have silver fluoride, which is different from silver diamine fluoride, and we'll talk about the difference. And stannous fluoride, used in clinical studies in Western Australia. Western Australia is a really rural area, and the government of Australia was trying to figure out how to get dental care to kids in an area where there just wasn't a lot of access to dentists, dental hygienists, and dental therapists. So they actually sent some dental therapists out to Western Australia to put these two medicines on teeth to try to stop those lesions from progressing until they could get dental care. And so that's where this comes from. And studies show that that actually worked. In the 1970s, silver diamine fluoride was developed by a graduate student in Japan. She's still actually alive, and she lives in the Okasaka prefecture. But it was part of her graduate thesis that she developed this medicament. And so it started to be used in Japan. And her studies showed that it was so effective that the the Ministry of Health and Welfare in Japan kind of bought the patent from her and started using it throughout their school system. In the 1990s, Brazil caught on to SDF and started recommending it for young school children. And then in the 2000s, we started having our first randomized controlled trials. I'm a public health trained healthcare provider, and so I love randomized controlled trials and population trials to get things, to see if there's actually evidence for things to work. And so these are some of the first ones that were done, and they were done on really large populations in Nepal, China, and Cuba. And then finally, in 2014, the FDA approved SDF for use in the US. And so you can see that we've had a huge, long history of silver use and then silver diamine fluoride use. But it was only recently that it was approved for use in the US. Why is that? Why is this thing that we know works take so long to get approval? Well, one, the FDA approval process is really tedious, and you need a lot of evidence. And while there is evidence and population-based trials, it's really hard to get a medicine approved for use in the US if there's not actually trials done in the US. And so since we didn't have it here, we didn't have those trials. So they kind of did this backwards way of getting it into FDA approval. So it was approved through a grandfather clause. Since it was on the market before 1976, they were able to use this clause to kind of sneak it in the back door of using this material. Its clearance isn't actually as a drug, it's actually as a device, because it's much easier to get a device approved than it is to get a drug approved. And you think back, if you've heard in the news of how it's hard to get cancer drugs approved on the market because you need so many trials and things like that. That's why you can understand how hard it is to get a drug approved. Devices are a different story, and they're a little bit easier. So this is called a Class 2 device. It's non-threatening. And I'll talk about why it's a device in a minute. I want to be very clear, though, that the approval was to treat dentin hypersensitivity for adults over age 21. Now, we don't use it like that, but that's what it's approved for, and that's what its on-label use is for. Who can think of another material that we use all the time in dentistry that's only approved to treat dentin hypersensitivity, but we use in a completely different manner? Yeah, fluoride varnish, exactly. So fluoride varnish went through the same FDA approval process as a device, not a drug, and this is how it all kind of came through. So same clearance and device class as fluoride varnish. So you can see this is a microscopy scope of dentin tubules, and you can see here those tubules are occluded. And so that's what happens with SDF. It occludes those tubules. Same thing as fluoride varnish. So that's why it's a device. So the device part is occluding the tubules, not as a drug interacting with proteins and other things in the body. What was really exciting is I was sitting in an American Academy of Pediatrics meeting in San Francisco, and it was a section on oral health, so there was a bunch of physicians who were really interested in oral health and a bunch of dentists, and everyone's cell phone started going off at the same time, and I was like, oh, what's happening? But it wasn't anything like big national news, but for us it was really exciting that the FDA has actually classified SDF as a breakthrough therapy drug. And which that means it can be fast-tracked through this FDA process of getting classified as a drug and classified for different uses through this faster process because it's such a good drug to have. And for me, with this, it wasn't so exciting that it was SDF could now be on this like fast special track, but that the FDA was recognizing that dental caries is a serious or life-threatening disease because they only approve these drugs if they're able to treat serious or life-threatening diseases. So I thought it was really, really interesting that they were recognizing oral health as a really important component of overall health. And they also said in this classification, you have to have this preliminary evidence that says that drug may demonstrate substantial improvements over the existing therapies. Our existing therapies, you can remember, are preventing that hole from happening in the first place with fluoride and diet and hygiene counseling, or just fixing the hole. If we can like actually stop the hole from getting bigger and stop the hole from needing that filling, that is a really good thing to have. So how does this stuff work? I know everyone's like really excited about dental materials, like super early in the morning. And it's like lots of chemistry on top of that. So first, the mechanisms of actions are SDF is antimicrobial. It gets that physical barrier, that device characteristics we talked about. And it's the highest fluoride system, delivery system on the market and that we've ever used. So first, silver is antimicrobial. Like we talked about, the Romans have used it. It's been used for centuries. Some of the very first successful surgeries done were because of silver sutures were available. The nice thing about silver, it really doesn't have a lot of toxicity to it. And it's broad spectrum, so it kills a lot of bacteria, gram-negative, gram-positive, but it doesn't hurt human cells at all. It's very biocompatible, so a lot of jewelry is silver because it's easy and it doesn't react. So you can understand when you might have friends who have nickel allergies that react to that. But having a silver allergy is very, very rare. So what happens with the silver ions is it reacts with the proteins and DNA in bacteria, and it damages that cell wall of bacteria that humans don't have. So when we're looking at antimicrobial things, we're looking at what is going to kill the bacteria, like what properties does the bacteria have that humans don't so it won't hurt us? Well, we don't have cell walls, which is great because the silver degrades those. It also inhibits DNA synthesis once it gets into those cells, and disrupts that intercellular metabolic activity. So once it's in the cell, once it's broken through that cell wall, it starts to break down the intermetabolic activity of the cell. There's a possible electrical component that also might contribute to that antimicrobial property of silver. And what happens is that those cells eventually die. So like literally these are silver bullets that are going into the cells. These ions act as major disruptors, and once they're in the cell, they completely damage things. So you can see these scans of bacteria where you can see these normal Staph aureus, and then as soon as you put the silver in it, they just start to break down. It's literally like sending silver bullets to these bacteria. Same thing happens in E. coli. You can see it's almost like, these are almost like action shots, right? You can see the cells exploding as these silver ions hit the cells. There's another mechanism which I think is really cool. It's when you have a bunch of bacteria that have been inundated with these silver ions then are trapped in the bacteria, they do their damage, but then those bacteria go to other bacteria that haven't been exposed to the silver ions, and they act almost like zombie bacteria, right? So these bacteria that are dead, filled with silver, go and like drift to other bacteria, then that silver is released to those other bacteria and they kill them. So it's like turning them into zombies as they go across. This paper literally said like zombie effect of silver ions, which I was like, must win an award for coolest scientific paper ever, name ever. It's my goal in life to like have something with zombie in it, right? So that's the zombie bacteria. So you'll hear about the zombie effect. So the chemistry, bear with me for a little bit, because chemistry was not my favorite in school, but I've really kind of had to go back and learn a lot of it to talk about this, this really cool ion. So you have silver and fluoride, right? So we know silver is antimicrobial. Fluoride, we all appreciate the effects in dentistry that it has. So to get those two together, you have to dissolve them in ammonia. And so once you dissolve those in ammonia, you can put that in water. And so before that, it's all solid. You can't actually use it. So once you put it in water, it now becomes like a liquid. And so now all these ions are in this liquid. And what this gives you is it gives you about 25% of the solution is silver, 5% is fluoride, but that actually translates to 44,000 parts per million. And then a little bit is ammonia, just to help that silver and fluoride dissolve together. And then most of the solution is water. So SDF Advantage Arrest is the SDF on the market in the US today. There are different brands in different countries, but that's the only one currently on the market in the US. So when it says 38% SDF, those are what the breakdown of things are. So you get this silver, which is antimicrobial. You combine it with fluoride, which we know is really great. And then it has a bunch of reactions that it goes through. So first is silver phosphate. It also gets calcium fluoride when you put it on the tooth. And then there's some silver protein complexes. In solution, this is clear. It's perfectly clear. It looks really nice. It looks like water. But once you expose it to oxygen, and we all need oxygen to breathe, right? It becomes silver oxide. And that oxygen causes it to be black. It causes it to be very black. And this is what it looks like. So you'll read papers and it'll be like, oh, SDF is this new cure. It's so great. We don't have to drill and fill anymore. It changes the tooth like a little bit different color. That's a lie. It changes it black. So I will go kind of through some different other pictures that I have, but when people are like, oh, it's fine, it just changes a different color, you have to wonder why they say it's just a different color. So on the left, you can see this active dentinal lesion, that really fuzzy dentin. And then you can see this arrested lesion, right, where it's nice and hard, it's smooth. So that's what that silver causes. And these are, this is an in vitro study of primary teeth. So you can see that lesion has lots of bacteria on the left, and then they can harbor lots of bacteria, and then it becomes smooth and hard on the right once you add that silver to it. So that silver diamine fluoride is known by a lot of different names throughout the literature, which makes it kind of hard to go back and read older papers. But these are kind of all the names that have been used to describe this medicament. Now, I started the last two because in the US, it's known as silver diamine fluoride with one M. And if you were kind of a chemistry nerd, you would know that amine refers to a covalently bonded amine group, while amine is for ammonia. So technically it should be two M's, but everyone in the US has been using it with one M for so long that we've just kind of gone with the one M. So you'll only see it with the one M, but you know deep down it's two M's. It's like that Kleenex versus tissue kind of thing now. So we're using the one M, but no, deep down it's ammonia. So that's what dissolves the silver and fluoride together in water. So what evidence do we have that this works? I've told you that it's been used for lots and lots of years, many, many years. But what does it actually do? So as a reminder, just so we're all clear, it's not approved for caries arrest. It's not approved for a cavity liner. It's not approved for preventing secondary caries, and it's not approved for use in children. We use it for all these things, but just so you're aware. So I've given you lots of these fun charts, and I won't go through all of them, but suffice to say that we have good evidence that this stuff works. It arrests caries. It stops that lesion in its tracks. It's amazing. It's like having that magic wand that I always wanted in dental school to be like, I need to fix this problem. I need this lesion to stop. So it does that. It does that really well. And you can see these are just different studies, and I won't go through all of them, but lots of high-level evidence, randomized control trials, cohort studies that have shown us that this medicament arrests caries. It stops caries in its track. you can see here as well, works even when you're using like chlorhexidine or oral hygiene instruction versus all the other things we've had in dentistry. This stuff actually works. It works about 80% of the time. And I'll go over like how you check and see if it works. We know that applying it between 6 months and a year is the best. A lot of practitioners will apply it more often than that. However, when we look at the literature, it says between 6 months and a year is best. We definitely need more evidence out there on this material. A lot of practitioners will apply it every 3 months. Some will apply it every 6 weeks. Those don't have any evidence behind them, but it works. And we have really limited data on children who are less than 3 years old. So when we do these population studies, you have to go out into the backwoods of Nepal and see kids. And so sometimes you're seeing the kids who can come or kids who are school age. So that's where our evidence comes from. It doesn't come from those really younger children. But in the US, we're using it on really young kids with good success. And you can see this lesion on the left, and then now it's black on the right. So it changes the lesion completely black, but not healthy tooth structure. As far as using it as an indirect pulp cap, a lot of practitioners will do this. They'll say like, oh, I'm in there, I might as well just like freeze the lesion and then put it on, put some glass ionomer or a different restoration on top of it. We don't have a lot of good evidence that this is good, and it might actually harm the pulp a little bit, but so far a lot of people are using it, and we don't have any evidence that you shouldn't or you should use it for indirect pulp capping. We do worry about that pulpal injury because ammonia is really caustic to the pulp of the tooth. So if you're really, really deep down in there, that ammonia can actually irritate the pulp and cause it to become necrotic. So you can see these are some teeth that I extracted and put some silver diamine fluoride on because I was just trying to see how long it took to turn black, because you first put it on there and it looks fine. And then you're like, oh, this is great. And then 24 hours later, I looked at them and they were jet black. I have some more pictures. As far as using SDF as a sealant, we don't really recommend that. There's no good evidence that says it's better than a sealant. In fact, it can actually say it's a little bit more harmful than a well-done sealant. So we don't really recommend it for those pit and fissure caries. So cost may be a factor here though, because doing a well-done sealant is hard. You have to isolate it, you have to use a lot of material, whereas this, you just paint it on. So that can be an effect, but we know that SDF doesn't work as well as a traditional sealant, so we won't be replacing our school-based sealant programs with SDF. A lot of people will use SDF in what's called the SMART technique. I think dentists live for making really fun acronyms. So this is called Silver Modified Atraumatic Restorative Technique. So they put silver diamine fluoride on the lesion and then cover it with glass ionomer, or a glass ionomer cement, or a resin-modified glass ionomer as an atraumatic technique. Especially, this is good for young children who can't sit through a dental procedure where you need to numb them and put the rubber dam on and do the restoration. We don't have a lot of literature evidence about this, but a lot of practitioners in the US have adopted this and are very adamant that this is a good practice. It requires really good follow-up because you just don't want to put this on there and then send them off into the wild and not follow up with them. And I also would stress that in the manufacturer's instructions for SDF, it says it's caustic to glass, and what does glass ionomer have in it? Glass. So be really careful if anyone says like, oh, we're just going to put SDF on everything and then put glass ionomer on it right afterwards. You need to give it time to dry almost before you put that glass ionomer on top of it, because otherwise it'll be caustic to it. And we really don't know the long-term evidence of this. Practitioners have only been using this in the US for about a year. So we're still seeing what the long-term results of this are. I gave this talk and the manufacturer emailed me a really long, nasty email about like, no, it's not caustic. And I was like, it's on this is literally your package insert. How do we code for this? Right now there's a new code. It's D1354 for interim application of caries arresting medicament. It's right now coded per visit, but the ADA is changing it to be coded per tooth. This is under this code, it says conservative treatment of an existing asymptomatic caries lesion by topical application without mechanical removal of sound tooth structure. That's what the code reads right now. I feel like this code is going to change, especially as we move forward and learn more about this medicament, but that's what it is right now. You can also code it as a 9910 application of a desensitizing medicament, because that's actually what its on-label use is for. Kind of the same thing as fluoride varnish. If you're using it actually to prevent sensitivity in a patient, this is what the code you should use for it. And I wouldn't recommend using the 1208 code, the topical application of fluoride, because this is kind of different than fluoride varnish and you're using it in a different way. It's all about the intent behind it on like what code you're going to use. So the most appropriate one would be this 1354 code. MA in Minnesota has told us they would approve this code for use. They have not yet as of to date. So right now a lot of families pay for this out of pocket. While I'm on the coding, I know it's materials and coding. It's like everyone's favorite topics. While I'm on coding, when I asked the Minnesota board about dental hygienists using this medicament, they said it kind of falls in the fluoride application, but it also falls under caries diagnosis. So if a dentist diagnoses the caries and says it needs to be treated, then a hygienist can apply this medicament. And we'll talk about how to apply it in just a second. But it shouldn't be just applied like fluoride varnish on patients without lesions. Does that make sense? And I think we'll get more clarification moving forward as we use this medicament more, as more insurances start to cover it, and things like that. So how do we use it? It comes in these 8 milliliter bottles, but it also comes in these like 0.1 milliliter single dose capsules. I work in the hospital with a lot of kids, and so most of my clinical practice is in the operating room, and we have to have single-use everything. So I wouldn't use this in the OR because I'm just doing definitive treatment, but these are great for if you have to be in a facility that requires like single-use treatment. So you can apply it with these fancy brushes that come with Elevate Oral Care, or you can just apply it with a micro brush. Micro brushes are much cheaper than these little things that come with it. So like every other patient, you do a thorough exam, caries risk assessment. You clean the teeth, and then you want to isolate these teeth, because like I said, it's a clear liquid, and you place it on anything, it'll turn it black. So this includes skin, fingers. I mean, everyone's wearing gloves now, but I'll show you some pictures of some residents that were handling it without gloves. You want to isolate it as best you can. If there are tissues around it, you want to put Vaseline on those tissues, so if you accidentally touch those tissues, it won't stain those tissues black. It takes about 1 to 2 drops. So the company says it takes about 1 drop for 5 surfaces of teeth. It's hard to kind of measure that out, but it takes a very, very little amount, just painting it on. You paint it on with a micro brush. You wait about 30 seconds to a minute, and then rinse off with water. And then you follow up within 1 to 2 weeks. The reason you want to follow up within 1 to 2 weeks is because you want to make sure the lesion's hard. Because SDF is great, but it only works about 85% of the time from the literature we have. So if the patient comes back and the lesion's not hard and smooth, you'll need to reapply it. It means that the silver wasn't taken up. It might have been washed out. The mouth is a very wet place. I'm usually applying this to children who are screaming and flailing around. So you're like, I think I got it on there, but it was a little chaotic in the moment. So follow up within 1 to 2 weeks and make sure it's hard. You can reapply every 6 months is the recommended assessment, but it really kind of just also depends on the hardness of that lesion. So we have a couple of studies looking at the use of SDF for those interproximal lesions, especially those E2 lesions, the ones that are just into enamel that you want to prevent from getting any bigger. A lot of practitioners have been putting this on superfloss and flossing down in between. It's a possible thing that's going to happen. We have a large study going on right now in different places in the US to look at this, but we don't have any evidence that that works right now. So it's really great, especially for lesions where you're prepping one tooth. You can see the demineralization on the other side, and so you can just put it in there. We don't really know if that works, but it's better than nothing right now, so we've been using this in our clinics. You know, I think for every high-risk individual, any individual who has a carious lesion, you're automatically in that high-risk category. So treat them like you would any other high-risk patient. They might need adjunctive fluoride, so a higher fluoride dentifrice. They might need more frequent recalls. They might need more education on their diet or hygiene. And you might also kind of look at these patients and say, like, all right, we're going to fix this one, but we want to prevent other holes from happening. Because SDF is great, but it doesn't restore that form and function of teeth. It doesn't build anything back up. So if, you know, the teeth are really broken down, it's not going to be the last treatment that that tooth receives. I think these are the pictures I have of the color change. So these are some extracted teeth. And I had just put SDF on them. And I'm like, oh, great. These teeth aren't changing color. 1 hour later, I come back, and they're dark. And then I come back 24 hours later, and they're jet black. I mean, this stuff is very black. So when people tell you it changes color a little bit, you're like, I feel like this is a lot bit. I think one of the most important things when I looked at these slides is when I looked at this is a tooth that has no SDF, and this is at 24 hours later. You can see that the silver has stained more than just that initial lesion. Do I have a pointer capability? Yeah. Oh. So you can see this lesion here and here, but this SDF has stained everything. So you have to be really careful with Caries lines and other areas of the tooth that are demineralized that might not look demineralized when you first look at it. But that silver will get into any cracks and Caries lines that tooth might have and also stain those black. Because wherever the silver goes, oxygen will go and change it black. Now, Elevate, the company that makes it in the US, they have really great marketers, and so they've spun this to be like, it provides really important clinical feedback. And you're like, well, I'm not sure the patient would have wanted this clinical feedback. So just be careful. It is hard because it's clear. They are coming out in about 3 months, I believe, with a solution that's blue and that still changes black, but you can at least see where the clearness is on those teeth. So that's just something to be aware of. I'm not sure if that's really going to change a lot, but it'll be you can at least see where it is. So if it's on your counter, you don't put your arm in it. This is a patient of mine. It's a 3-year-old that we did SDF therapy. We were trying to prevent this child from going to the operating room. We ended up later going, but we just needed to freeze things in place for the moment. Like I said, Vaseline is really good to put on soft tissues to prevent that medicament from sticking. So this is a friend of mine in North Carolina. She was doing this on her neighbor's child and was isolating the tooth with an isolite. She's like, I don't know how it happened, but a little bit got into the isolite and got sucked up in the saliva and back against the cheek, and then the stain happened. Fortunately, it resolved in 2 weeks, but she was really not happy, and the neighbor was fortunately very understanding because they also prevented from having to drill out a cavity, but this can be what happens, so just be really aware and very, very careful with this stuff. Some studies have looked at trying to, fix that problem with SDF, right? Because if SDF just was clear or even better white, it would be awesome. It would be like the best medicament ever. It would be the magic wand in dentistry that I've always wanted. So some people have been rubbing iodine on it right afterwards, but you can see that even with iodine, it initially is less dark, but over 24 hours later, it's dark again. That silver is really reactive, so it's that silver oxide. If you've ever had to polish silver, you understand, it changes black and it's hard to get off. So yeah, you can see it's still really dark. These are a little disc of hydroxyapatite, so to simulate teeth. Because it's so dark, I think it's really important to have informed consent. And I actually, in our clinic, we have a separate informed consent form for it with lots and lots of pictures. And I think everyone in the family should be on board with it, because what you don't want is to apply it with one guardian. Child goes home, teeth are super black, and then the next guardian comes in the next day to your office and is very upset about it. Because that's happened, and we've seen that happen a lot. So I usually send home things, have everyone on board, have all decision makers understanding that this is what happens when it turns black. Pictures are great for health literacy, because I can say it stains it black, but they're like, oh, it's fine, it's already kind of dark anyway, it's a cavity. But you want to understand it changed really black. So last year in the New York Times, this was the headline, and I was like, oh, that's a little misrepresentative, but that's okay. And they had great phrases like, you don't need to drill and fill, you don't need an injection, it's painless, and it is. SDF is painless. It kind of stings a little bit if you put it on your tongue, like a little tingly, but nothing like pain. And, it's just, you paint it on. They were using lots and lots of words that sound really great, like better, faster, cheaper, what everyone wants out of dental care, right? And at the very, very end of the article, they were like, it kind of blackens the brownish decay on a tooth. So just be aware. I think when families come in with questions, you can say like, yes, this is a great liquid. It's a great thing we have, but these are the things you should be aware of. So indications for it. Dental hypersensitivity, that's what it's approved for. We've actually used this in a couple of cases where children had really severe acid reflux and GERD, and their enamel has been worn away and they're really sensitive. And what we used to have for that was putting a stainless steel crown on it. But now we have SDF, and especially if it's in the posterior, it's a great medicament to paint on that tooth. It's really helped these kids a lot with that sensitivity. A lot of pediatric dentists love this medicament because it's helpful with challenging behavior. Trying to do a filling on a 2-year-old is challenging, to say the least. And a lot of times we have to use other things, like going to the operating room or having sedation. So this is a much less invasive way of kind of buying some time for those teeth. So a lot of pediatric dentists have fully embraced this medicament for kids with challenging behavior. It's also great for patients who are facing medical challenges where you can't fix their teeth at the time. This patient, he's a 14-year-old Chinese boy, and he's suffering from beta thalassemia. And what he needed was dental work done, but he couldn't even brush his teeth. His teeth were so sensitive. But he couldn't have the dental work done because his medical condition was too unstable to allow for dental treatment. So what happened was they started putting SDF on. So this is the picture I showed you earlier. It changes very, very black. But it was great. It bought him some time until his medical condition could be more stable. And so then they were able to do some veneers over it. And they later did the lower anteriors as well. So it's a nice thing. It kind of freezes that cavity in place so you can buy some time and in order to have more time to address it. And so this is also great for areas where we don't have access to care to go into the operating room immediately. When I was in residency training, our operating wait list was 8 months long. And so that's just too unacceptable to a lot of families, and the cavities are just going to get worse in that time. So this is a great thing to freeze those lesions in place. Obviously, a contraindication is if you have that rare silver allergy, and patients will usually know because they've had contact with silver before. It's a very ubiquitous element in our daily lives. If you have any open mouth sores, you can cover them with petroleum jelly and do it, but what will happen is that silver and that fluoride will burn those open wounds and feel really uncomfortable. Teeth with irreversible pulpitis, they need nerve treatment or they need extraction. They don't need this medicament to go over the top of them. Enlarged decay, because like I said before, this stuff doesn't restore form and function, and you might have space loss in there as well. This is one of my residents who just was putting the bottle back for us, and someone didn't wipe the bottle down and make sure it was really dry. And you can see that that staining was there. That stain lasted about 4 weeks for that resident. Now, if you get it on your fingernail, you just kind of have to wait for the fingernail to grow out. So just be really, really careful. We solely handle this with gloves. I think for kids, a lot of people are saying like, oh, SDF is it now. We can just stop drilling and filling on kids. But I think it's important to consider the psychosocial implications because we have limited evidence for kids, what it means to turn their teeth black. Because if they have those anterior caries, they might also be of lower socioeconomic status. They might not be in a household where they're getting like full medical and dental care anyway. And so on top of that, we're going to change their teeth black, and they're going to go to preschool, and they're going to go to school. I think those are things we should consider before just reaching for this magic bottle full of black magic. Because we know this, like lots of caries are indicative of lower socioeconomic status. The only evidence we have of this is that we looked at kids who had silver crowns placed in the anterior and their psychosocial implications, and those kids had more negative feelings toward other kids about discolored teeth, and they were more conscious about it. So kids know, a 4-year-old knows what this means. So I think instead of reaching just for this. And I tell pediatric dentists, like, don't just go for this bottle. Like, we do these things, we're dentists because it's hard. We make connections with these families. So this is a really great medicine. It's new on the market. I hope that dental material experts come out with new materials a lot like this, but don't change it black. So it's another great tool that we have in our toolbox. And I'd just like to thank all my residents and my co-faculty at the University of Minnesota for help with pictures. And since this has been so new, we haven't had it for very long. I don't have this huge picture bank. And I sometimes give talks where I show where we work. And we work on both sides of the Mississippi River. And it's going to look like this in a couple months. And I'm just glad it doesn't look like this in a couple months. So, yeah. I am happy to take questions, and please feel free to email me too afterwards if you have anything you'd like to know.